Hello and good day. We are the Group 2 here to present 3 chemotherapeutic agents. I am Angelita Tumula, starting off with antiviral agents. Viruses are obligate intracellular microorganisms that replicate inside living cells and cause a variety of adverse conditions within the body. Viruses cannot replicate on its own and thus uses their host cells to synthesize their own protein, DNA, and RNA. The replication process of a virus begins when a virus attaches to a cell and enters inside, after which it uncoats and begins to replicate viral genome. It is followed by the synthesis of capsids and assembly of new virions before it is finally released. An antiviral agent is a medication that inhibits the replication process of the virus, meaning it interferes with the virus's capabilities to reproduce, either through interfering with early events like binding to cells and uncoating, interfering viral nucleic acid synthesis and/or regulation, or inhibit viral protein synthesis. There are 4 classes of antiviral agents. First, we have agents for influenza and respiratory viruses. Now, influenza is more commonly known as the flu, which is a respiratory infection that mainly affects our nose, throat, and lung. The mechanism for anti-influenza drugs is to inhibit viral replication, possibly by preventing the uncoating of the virus. Agents for influenza A and respiratory viruses include amantadine, oseltamivir, ribavirin, rimantadine, and zanamivir. These drugs are commonly introduced to the body through the oral route and once or twice a day, with an increased dosage for adults compared to children, except for ribavirin or virazole that may be administered by nasal inhalation or by aerosol inhalation with a small particle aerosol generator. After oral administration, amantadine and rimantadine are well absorbed in the GI tract and widely distributed throughout the body. Amantadine is eliminated primarily in urine. Rimantadine is extensively metabolized and then excreted in urine. Ribavirin, on the other hand, is rapidly absorbed and are distributed in plasma. It is metabolized in the liver and by RBCs, and then excreted primarily by the kidneys, with some excreted in feces. Contraindications and caution include renal impairment and pregnancy and lactation, particularly amantadine, zanamivir, and oseltamivir that can alter metabolism and excretion of drugs. They should also be only used for treatment of pregnant or lactating patients if the benefits outweigh the risk. Use of these antiviral agents is frequently associated with various adverse effects that may be related to possible effects on dopamine levels in the brain and can include, but are not limited to, lightheadedness or dizziness and nausea. The following are drug-to-drug interactions involved in the use of agents for respiratory viruses. Anticholinergics with amantadine or rimantadine increase atropine-like effects and loss of effectiveness with acetaminophen and aspirin. Antacids and NRTIs reduce the effectiveness of ribavirin. Isoniazid increase incidence of rifampin-related hepatitis. Antiarrhythmics, hormonal contraceptives, corticosteroids, antifungals, and CNS depressants also have a decreased effectiveness if combined with rifampin. Next are the important nursing considerations when administering antiviral agents for influenza A and other respiratory viruses. For assessment, obtain a baseline assessment of the patient's viral infection. Reassess regularly to monitor the drug's effectiveness. Assess for adverse reactions and drug interactions. Assess the patient's and family's knowledge of drug therapy. Next is the possible nursing diagnosis. Acute pain related to gastrointestinal, CNS, or GU effects of the drug. Disturbed sensory perception related to CNS effects of the drug. And deficient knowledge regarding drug therapy. For the implementation, administer drug as prescribed as soon after exposure to the virus is possible to enhance effectiveness and decrease the risk of complications due to viral infection. Administer influenza A vaccine before the flu season begins, if at all possible, to decrease the risk of contracting the flu and decrease the risk of complications. Instruct the patient about the appropriate dosing. Safety precautions including changing positions slowly and avoiding driving and hazardous tasks that should be taken if CNS effects occur. The need to report any adverse effects such as difficulty walking or talking to enhance the patient knowledge about drug therapy and to promote compliance. Educate client on drug therapy to promote understanding and compliance. And last but not the least, for evaluation. Patient doesn't incur injury while receiving drug therapy. Patient maintains adequate hydration. Patient and family demonstrate an understanding of drug therapy. And that's it for the antiviral agents for influenza A and respiratory viruses. Up next, we have agents for herpes and cytomegalovirus. Herpes results from infection with the herpes simplex virus or HSV. It causes sores or blisters to form in or around the mouth or genitals as well as other symptoms. These agents are used to the infections caused by herpes such as cold sores, encephalitis, shingles, and genital infections, and CMV infections such as infections affecting the eyes, respiratory tract, and liver. The mechanism for anti-herpes and CMV drugs is to inhibit viral DNA replication by competing with viral substrates to form shorter, non-effective viral DNA chains. Agents for herpes and cytomegalovirus include acyclovir, cidofovir, famciclovir, foscarnet, ganciclovir, valacyclovir, and valganciclovir. When given orally, acyclovir absorption is slow and only 15 to 30% complete. It is distributed throughout the body and metabolized primarily inside the infected cells, and most of the drugs is excreted in urine. Famciclovir is less than 20% bound to plasma proteins. It is extensively metabolized in the liver and excreted in urine. Ganciclovir is administered IV because it is absorbed poorly from the GI tract. More than 90% of ganciclovir isn't metabolized and is excreted unchanged by the kidneys. Valacyclovir is converted to acyclovir during its metabolism and has pharmacokinetic properties similar to those of acyclovir. It is metabolized in the intestinal wall and liver to ganciclovir. However, interchanging the two drugs isn't effective. Contraindications and cautions include: if the patient has a known allergy to drug, this is to prevent hypersensitivity reactions. And then we have renal impairment, pregnancy and lactation, severe CNS disorders, and children in general, since foscarnet, ganciclovir, and valganciclovir can affect bone development and growth, especially children with AIDS, since cidofovir has potential carcinogenic effects and effects on fertility. Further adverse effects are associated with GI upset and nausea, confusion, insomnia, and dizziness, a rash, inflammation, or burning sensation at the IV and topical site. There also have been adverse effects of some drugs, particularly cidofovir and ganciclovir, valganciclovir, and foscarnet, that is associated with severe renal toxicity, bone marrow depression, and seizures. The drug-to-drug interactions involved are increased renal toxicity with aminoglycosides and increased risk of drowsiness with zidovudine. Next are the important nursing considerations when administering antiviral agents for herpes and CMV. For the nursing assessment, it is quite similar to the previous nursing consideration of anti-influenza. For diagnosis, ineffective protection related to adverse hematologic reactions, risk for deficient fluid volume related to adverse GI reactions, and deficient knowledge related to drug therapy. As for the implementation, monitor renal and hepatic function, CBC, and platelet count regularly, the patient's mental status when giving the drug IV, hydration status if adverse GI reactions occur. Follow the manufacturer's guidelines for reconstituting and administering these drugs, obtaining an order for an antiemetic or antidiarrheal drug if needed. Take safety precautions if the patient has adverse CNS reactions. Instruct the patient on how to prevent spreading the infection. Finally, nursing consideration for evaluation. Monitoring patient response to therapy and the adverse effects. Evaluating patient understanding on drug therapy. And lastly, monitoring patient compliance to drug therapy. And that's it for the antiviral agents for herpes and cytomegalovirus. Up next, we have agents for HIV and AIDS to be reported by Mr. Roque.
So good day to you, sir, and good day to all of you classmates. Now I am going to report about the antiviral agents for HIV and AIDS. So first I am going to discuss the difference between HIV and AIDS. So what is HIV? HIV, or human immunodeficiency virus, is a retrovirus that infects immune cells, notably known as CD4 T cells. And these CD4 T cells are significant in our immune system since they fight off infection. And without it, our body is susceptible to opportunistic infections. Retrovirus means that this virus uses RNA to infect the host cell. And if it's left untreated, HIV can further progress into AIDS, or acquired immunodeficiency syndrome, in which the person can be diagnosed with AIDS if its CD4 T cell count falls below 200 cells per microliter of blood. And the normal CD4 T cell count of our body is 500 to 1,500 cells per microliter of blood. And to prevent the progression of HIV to AIDS, we have these antiviral agents for HIV that differs on their mechanism of action. We have the non-nucleoside reverse transcriptase inhibitors, the nucleoside reverse transcriptase inhibitors, and so on. And under this mechanism of action, we have the different drugs under their category. First is the non-nucleoside reverse transcriptase inhibitors. It binds directly to HIV reverse transcriptase, blocking both RNA and DNA-dependent DNA polymerase activities. To understand it, let's discuss the role of reverse transcriptase enzyme. So, as you can see in the picture, this is the reverse transcriptase enzyme. This is the viral RNA, and this is the NNRTI, or the non-nucleoside reverse transcriptase inhibitors. So, the role of this reverse transcriptase enzyme is to bind to this viral RNA to formulate viral DNA by attracting or by pairing of the host nucleotides towards this viral RNA. And we don't want a viral DNA to be formulated inside the host cell, because once the viral DNA is being formulated in the host cell, the cell will become a virus-producing cell. That's where this NNRTI plays. So to prevent the formation of the viral DNA, the NNRTI will bind to this reverse transcriptase enzyme, and it will not bind here to the viral RNA, thus preventing the formulation of viral DNA. Under this classification or mechanism of action, we have these different drugs, namely the delaverdine, efavirenz, and so on. And the dosage or route and usual indications. And under this classification, the route is by mouth. All of them are by mouth. And just read it, guys, na lang to save time. Okay, so pharmacokinetics. In terms of pharmacokinetics, the drugs under this classification is rapidly absorbed in the GI tract, distributed towards the targeted cell, and metabolized in the liver, specifically in the P450 cytochrome system, and excreted via urine, feces, or both. And for example, the efavirenz peak level, I also indicated the peak level and half-life here. Peak levels in 3 to 5 hours, excreted in the urine and feces, and its half-life of 52 to 76 hours. Contraindications and cautions. There are no adequate studies of non-nucleoside reverse transcriptase inhibitors in pregnancy, so you should be limited to situations in which the benefits clearly outweigh any risk. So we have to outweigh the benefits over its risk when this drug is administered to pregnant women. And guys, HIV can be transmitted via bodily fluids, which includes this semen, vaginal fluids, our blood, including the breast milk. That is why it is indicated that women with HIV should not breastfeed, because again it can be transmitted via breast milk. Adverse effects includes GI-related, dry mouth, constipation, diarrhea, nausea, and so on. Clinically important drug-to-drug interactions. Just read it na lang, guys. Here, everything is being discussed in the PowerPoint. Okay, and let's go to the nucleoside reverse transcriptase inhibitors. This mechanism of action, it competes with the naturally occurring nucleosides within a human cell that the virus would need to develop. So let's again discuss the role of the reverse transcriptase enzyme. So this is the reverse transcriptase enzyme, and this is the viral RNA. And this is the NRTI, or the nucleoside reverse transcriptase. As you can remember, this viral RNA through the reverse transcriptase will pair up with the DNA nucleoside of the host cell. And here comes the nucleoside reverse transcriptase inhibitors. Instead of the DNA nucleoside of the host cell that will pair up to this viral RNA, it is now the NRTI that will pair to this viral base pair of the viral RNA, interrupting the pairing or the formulation of the viral DNA. Okay, and under this classification, we have these different drugs with its usual dosage or route and usual indications. And pharmacokinetics, it is again absorbed in the GI tract, distributed to the targeted cell and metabolized in the liver, and excreted by urine, feces, or both. And again, I indicated the half-life here and the peak level of the drugs rather. Contraindications and caution. Again, we have to remember that women infected with HIV are urged not to breastfeed. And among the drugs under this classification, zidovudine is proven to be safe when used during pregnancy. So this is the only drug that has been proven to be safe to be administered among pregnant women. Adverse effects includes serious to fatal hypersensitivity reactions such as fever, chills, rash, fatigue, GI upset, flu-like symptoms. Other adverse effects are indicated in the slide. Clinically important drug-to-drug interactions under this classification are mentioned on the slide. So just read it na lang, guys. Pause and read it. And now, the third is the protease inhibitors. It blocks protease activity within the HIV virus. So let's discuss the protease, the role of protease towards the infection process of the HIV to understand how this protease inhibitor suppress or prevents the HIV from replicating itself. So protease is significant towards the fibrillation of viral proteins of the HIV. As you can see in the picture, this is the HIV mRNA, and this is they call this the reverse transcriptase enzyme. And the polypeptide chain is formed during the replication process. And this polypeptide chain is being, I forgot the term. Basta meron siyang i-cut by this protease to make viral proteins. Ano na siyang duha viral proteins na siya. Viral proteins, and this is important in infecting new cells, kaning viral proteins. So the role of protease inhibitors is to bind to this protease enzyme so that this protease enzyme is incapable now of cutting this polypeptide chain that can be formulated into viral proteins. Under this classification, we have these different drugs, dosage route, and usual indications. And kindly read this na lang, guys. Pharmacokinetics, okay, it is also absorbed in GI tract. This inhibitor is targeted towards the targeted cell, metabolized in the liver, and excreted via urine, feces, or both. And I also indicated the peak levels and half-life of the drug. Contraindications and cautions. Okay, I indicated the slide here all information with regards to contraindications and cautions of the drugs under this classification. I included them all since I find it important. Adverse effects, as with antivirals, patients taking these drugs often experience GI effects, including nausea, vomit, and diarrhea, and so on. Clinically important drug-to-drug interactions are mentioned on the slide. Okay. And now, for the fusion inhibitors. For fusion inhibitors, it prevents the fusion of the virus with the human cellular membrane. So to understand it, we will discuss how this HIV virus penetrates or fuses towards the cell or the host cell. So the picture, this is the virus with its glycoprotein, and this is the GP120 if I'm not mistaken. And in the cell membrane or the cell membrane, the CD4 cells, we have the CD4 receptor for the HIV glycoprotein to attach. So this glycoprotein will undergo conformational change or internal arrangement for it to attach the CD4 receptor. And the role of fusion inhibitors is to attach to this glycoprotein GP120 so that this glycoprotein or the GP120 will not undergo conformational change. Thus, it will not bind to CD4 receptor because it needed first to undergo conformational change before it can be attached to the CD4 receptor. I hope that's clear. And for under this classification of drugs, we have this drug enfuvertide, if I pronounce it correctly, with its dosage or and route and usual indications. And it's in terms of its pharmacokinetics, it is metabolized in the liver, recycled in the tissues, and not excreted. The half-life of the said drug is 3.2 to 4.4 hours. And the drug is contracted with hypersensitivity, caution in the presence of lung and disease pregnancy, and adverse effects includes insomnia, depression, peripheral neuropathy, and etc. Now let's go to CCR5 co-receptor antagonist. It blocks the receptor site on the cell membrane to which the HIV virus needs to interact to enter the cell. To understand it, we will discuss the role of the CCR5 co-receptor. So, diba si HIV virus will, specifically the glycoprotein, the GP120, will undergo conformational change for it to attach to the CD4 receptor. And this is the CD4 receptor, guys, and this is the CCR5 co-receptor. So once ma-attach na si glycoprotein GP120 to the CD4 receptor, dili pa na siya fuse sa cell, sa host cell. It needs to attach pa sa CCR5 co-receptor. Okay. Muna siyang may tabo. And then, sige ma'am. Once ma-attach na siya, ang next step is ang glycoprotein mo-attach sa CCR5 co-receptor. And the role of the CCR5 co-receptor antagonist, instead nga ang kadtong glycoprotein sa virus ang ma-attach, naana ni si CCR5 co-receptor antagonist na nakaka-touch daan, preventing the binding of the CCR5 co-receptor to the glycoprotein of the virus. I hope clear na. And under this classification or mechanism of action, we have this drug, one and only maraviroc, with its dosage or route and usual indication. Okay, the pharmacokinetics is indicated on the slide, and contraindication cautions and clinically important drug-to-drug interactions. Adverse effects include severe hepatotoxicity has been reported with this drug, and CNS effects include dizziness. Changes in consciousness have been also reported. Now, let's go to the integrase inhibitor. Integrase inhibitor, under this mechanism of action, we have this drug, raltegravir. It inhibits the activity of the virus-specific enzyme integrase, an encoded enzyme needed for viral replication. By blocking this enzyme, prevents the formation of HIV provirus and leads to a decrease in viral load and increase in active CD4 cells. So, the integrase or the enzyme integrase, this is the enzyme integrase, is responsible for the integration of the viral DNA towards the host DNA. So this integrase contains magnesium, in which the the viral DNA and the viral RNA will attach. And for it not to happen, we have this integrase inhibitor. The integrase inhibitor will attach to this magnesium ion, so therefore there will be no integration of the viral DNA and the host DNA. And under this drug classification, the pharmacokinetics is rapidly absorbed in the GI tract and metabolized in the liver. It has a half-life of 3 hours and is secreted primarily in the feces. Contraindications and cautions includes hypersensitivity to any component of the drug. Adverse effects includes headache, dizziness, and increased risk for development of rhabdomyolysis and myopathy. So what is this rhabdomyolysis? This breakdown of muscle fibers that leads to leakage of muscle contents in the circulation, and myopathy is a general term for any disease that affects the control of voluntary muscles. Okay, so now for nursing diagnosis related to drug therapy in relation to these antiviral agents for HIV and AIDS includes the following: acute pain related to a gastrointestinal, CNS or dermatological effects of the drugs, disturbed sensory perception, imbalanced nutrition less than the body requirements related to GI effects of the drugs, risk for injury related to CNS effects of the drugs, and deficient knowledge regarding to drug therapy. So again, I just want to make some clarifications that the antiviral agents mentioned are not the cure towards HIV. These are just mga like drugs that will prevent the development of HIV to AIDS. Actually, there are two types of cure in relation to HIV and AIDS. We have the sterilizing cure and the functional cure. Sterilizing cure is a total eradication of the virus with no absolutely virus left in the body, and this is true to cases with German patient and Berlin patient. If I'm not mistaken, there are 3 patients that are cured, like literally cured, with no virus left in the body, and they are classified in the sterilizing cure. And for this antiviral agents, they are classified in the functional cure, in which the virus is basically in remission, but there is still a small amount of the virus left in the body. So if mo stop kag intake sa antiviral agents, mubalik na sad na sila og replicate. Okay, that is all.
Okay, and the next topic is about the anti-hepatitis B agents. So hepatitis B is a serious to potentially fatal viral infection of the liver. The hepatitis B virus can be spread by blood or by blood products, sexual contact, or contaminated needles or instruments. And healthcare workers are at especially higher risk for contracting hepatitis B due to the needle sticks. Hepatitis B has a higher mortality than any types of hepatitis. Individuals infected may also develop a chronic condition of chronic or become a carrier. So in the past, hepatitis B was treated with interferons. In 2004 and 2005, Adifovir or Hepzera and the entecavir or the Baraclude were the first drugs approved especially for treating chronic hepatitis B. And then in 2006, another NRTI, the talbivudin or Tyzeca, was found to be very effective in preventing viral replication in active hepatitis B patients. Okay, so next, listed in the table above were the drug name, the dosage or the route, and the usual indication. So our first drug for the anti-hepatitis B is Adefovir or Hepzara. So it is for adult, also for child 12 years and older, 10 milligrams per day via PO and reduced dose with renal impairment. And for the indication, treatment of hepatitis B with evidence of active viral replication and persistent elevation in liver enzyme. Then our second drug is Entecavir or the viral flu. So its route is it's for adults and children 16 years older, 0.5 milligrams per day via PO, also receiving lamivudine, and then 1 milligrams per day via PO, reduced dose with renal impairment. And then the third drug is telbivudin or the Tyzeca. So its route is it's for adults and children above 16 years old, 600 milligrams per day via PO, reduced dose with renal impairment. So these drugs are rapidly absorbed from the GI tract with peak effects occurring in 0.5 to 1.5 hours in the case of Entecavir, while 0.5 to 4 hours for Adefovir and 1 to 4 hours for telbivudin. So Entecavir and Adefovir are metabolized in the liver and excreted in the urine. Telbivudin is excreted and changed in the urine. Adefovir has a half-life of 7.5 hours, Entecavir has a half-life of 128 to 149 hours, and telbivudin has a half-life of 40 to 49 hours. So it is not known whether any of these drugs crosses the placenta or enters the breast milk. Okay, so for the contraindication and cautions, these drugs are contraindicated with any known allergy to the drugs to prevent hypersensitivity reactions and with lactation because of potential toxicity to the infant. Use caution when administering these drugs to patients with renal impairment and severe liver disease because of increased toxicity with these drugs, and those who are pregnant because the effects on the fetus are not known. So for the adverse effects of these drugs, the following are headache, asthenia, nausea, severe to fatal hepatomegaly with steatosis, nephrotoxicity, lactic acidosis, and exacerbation of hepatitis B when discontinued. So therefore, teach patients the importance of not running out of their drugs and use extreme caution when discontinuing these drugs. Okay, so now the clinically important drug-drug interactions. So there is an increased risk of renal toxicity if these drugs are taken with other nephrotoxic drugs. So if such a combination is used, monitor the patient closely, and then an evaluation of risks versus benefits may be necessary if renal function begins to deteriorate. And then for the nursing diagnosis related to drug therapy might include the following. Number 1, acute pain related to the central nervous system and GI effects of the drug. Second, imbalanced nutrition, less than body requirements related to the GI effects of the drug. And third is the deficient knowledge regarding drug therapy. Okay, so in continuation, the following are the topics regarding anti-hepatitis C agents. So, Simiprevir or the Olisho, Sofosbuvir or the Suvalde, and Daclatasvir or the Daclinsa as well as a number of drugs only available in a combination product are approved for treating hepatitis C. So people can get hepatitis C virus in a number of ways, including exposure to blood that is infected with the virus, being born to a mother with HCV, sharing a needle, having sex with an infected person, sharing personal items such as a razor or a toothbrush with someone who is infected with the virus, or from unsterilized tattoo or piercing tools. As shown in the table above, it is the drug for the anti-hepatitis C agents. So it is indicated there, the drug name, the dosage or the route, and the usual indications. So our first drug is declotesfer or the Defenza. So it is for adults 60 milligrams per day via PO with sulfospofir for 12 weeks. So treatment of hepatitis C genotype 1 or 3 in adults with compensated liver disease given with sulfospofir. And then our second drug is semaprevir or the Olisio. So it is for adult 150 milligrams per day via PO for 12 to 36 weeks. So for the indication, it says there that treatment of hepatitis C in adults with compensated liver disease might be given with pigeon interferon and ribavirin. So may combine with sulfospofir in genotype 1 for 12 to 24 weeks. And then the third drug is sulfospofir or the Sovaldic. So it is for adult. Its dosage and route. It's for adult 400 milligrams per day via PO for 12 weeks with pigeon interferon and ribavirin for genotype 1 or 4. And then with ribavirin for 12 weeks for genotype 2 or 24 weeks for genotype 3. So they can be used in combination. The new drugs approved for treating these diseases are protease inhibitors. They can be used in combination with ribavirin or ribavirin and pigeon interferon or other hepatitis C drugs to treat chronic hepatitis C in patients with compromised liver function. So for the pharmacokinetics of these drugs, so these are oral drugs that are readily absorbed from the GI tract, metabolized in the liver, and excreted in the urine. And then so half-lives range from 4 to 10 hours. These drugs must also be taken with pigeon interferon and ribavirin. Declotesfer is taken with sulfospofir with or without ribavirin. And then for the contraindications and cautions, so these drugs are contraindicated with any known allergy to the drugs to prevent hypersensitivity reactions and with lactation and pregnancy because these drugs must be given with ribavirin, which has known toxicity to the infant. Then, use caution when administering these drugs to patients with severe liver disease because of increased toxicity with these drugs. And then, safety has not been established for use in patients who also have hepatitis B and or HIV infections because exacerbations of these diseases might occur. And then the most common adverse effects are fatigue, nausea, diarrhea, and rash. Also, severe skin reactions can occur. And then for the clinically important drug interactions, so toxic effects or loss of therapeutic effect could occur if combined with other protease inhibitors or other antivirals. So if combining any of this, check a drug reference to make sure dosage is adjusted as needed. St. John's wort should be avoided as it leads to loss of effectiveness. And then for the nursing diagnosis related to drug therapy might include the following. Number 1, acute pain related to the CNS and GI effects of the drug. Number 2, imbalanced nutrition, less than body requirements are related to the GI effects of the drug. And then number 3, the deficient knowledge regarding drug therapy.
Aside from the antiviral agents, we have another topic which is the antifungal agents. But before we do that, we will start a reporting with a pre-test. We have 3 questions, all are multiple choices, and we will be giving you 3 seconds to answer it. No need to write, just say it out loud while watching the video. Let's go. For our first question, it is defined as a group of drugs used to treat fungal infections. A. Fungus, B. Tinea, C. Azoles, or D. Candida. The correct answer is C. Azoles. Next, what do you call a disease caused by a fungus? A. Fungus, B. Tinea, C. Candida, or D. Mycosis. The correct answer is D. Mycosis. Last, it is a fungus that is normally found on mucous membranes. A. Candida, B. Fluconazole, C. Fungus, or D. Ergosterol. Correct answer is A. Candida. Now let's learn what is antifungal agents. This is a fungal cell wall and it differs from the bacteria because of the rigid cell wall present in fungus and the cell membrane that contains ergosterol. The incidence of fungal infections increases and this might happen to any individuals, which we must remember the drug therapy differs in its reaction to a human body. Because for children, the antifungal drugs may cause severe reactions and they are sensitive to it. To adults, which these drugs might be very toxic to their body, our senior citizens that are more susceptible to the adverse effects, and lastly, we must remember that the pregnant and nursing women should not be given the antifungal drugs randomly unless the benefit outweighs the risk. Next is the systemic antifungal, or either kill the fungus or fungicidal, or inhibit the fungal growth, also called fungistatic. The systemic antifungal drugs can be very toxic and it requires extreme care and monitoring to make sure that the right drugs is used and to prevent severe toxicity. Under the systemic is azoles. As mentioned earlier, azoles are a group of drugs used to treat fungal infections. This might either be systemic or topical fungal infections. The drugs that belong to the azoles are the following: fluconazole or diflucan, itraconazole or sporanox, ketoconazole or nizoral, posaconazole or noxaphil, terbinafine or lamisil, and lastly, voriconazole or pen. Azoles may be less toxic, but it may also be less effective on cases that have severe and progressive infections. As for the therapeutic actions and indications, the drugs bind to sterols that may cause cell death or may interfere with cell replication, but it depends on the type of fungus present and the concentration of a drug. We have here a video that can help you to visualize it.
The azoles have broad-spectrum antifungal activity. They impair ergosterol synthesis by inhibiting the fungal cytochrome P450-mediated enzyme 14-alpha demethylase, inhibiting demethylation of lenesterol and accumulation of methylsterols. Lack of ergosterol leads to disruption of fungal cell membrane.
Meanwhile, for ketoconazole, fluconazole, and itraconazole, it blocks the activity of a sterol and the activity of human steroids, as well as the testosterone and cortisol. While for posaconazole and voriconazole, it inhibits the synthesis of ergosterol. And lastly, terbinafine blocks the formation of ergosterol and the cytochrome P450 to the 6 enzyme system. Now let's identify the pharmacokinetics of each drug. First is ketoconazole. It is administered orally. There are also available shampoo and cream, absorbed rapidly with the peak levels that means the highest concentration of a drug in the patient's bloodstream, is within 1 to 3 hours. It is metabolized in the liver and excreted through feces. For fluconazole, it is administered orally, and there are also IV. It can also be via IV, absorbed slowly if oral, and rapidly for IV. It has peak levels within 1 to 2 hours for oral and 1 hour for IV. It is metabolized also in the liver and excreted in urine. The third is uh, itraconazole. It is also administered orally, but it is absorbed slowly, metabolized in the liver by CYP450 or cytochrome P450, which is our group of enzymes, and excreted through urine and feces. Next is posaconazole. It is administered also as orally, but compared to itraconazole, it is absorbed rapidly. It has a peak levels within 3 to 5 hours and metabolized in the liver, excreted through feces. The terbinafine is administered orally. They're also available in sprinkle formation for the children. It has a rapid onset of action, metabolized in the liver, excreted in the feces with a half-life of 36 hours. The same with fluconazole, voriconazole, also administered orally or with IV. Absorbed slowly if oral and rapidly for IV. It has a peak levels of within 1 to 2 hours for oral and onset of infusion for IV. Metabolized in the liver, excreted in urine with a half-life of 24 hours. The contraindications and cautions for each drug. First, we will discuss the ketoconazole. It is associated with severe hepatic toxicity, should be avoided in patients with hepatic dysfunction in order to prevent the hepatic toxicity. It is also not a choice for patients with endocrine or fertility problems because it can cause an effect during the process, and for male, it affects the testosterone production and lessens the sperm production if it is taken as a pill. However, no evidence shows that the cream ketoconazole harms the fertility. Fluconazole, it should use with caution for patients with liver or renal impairment because it may result to liver or renal toxicity. For itraconazole, it is also associated with hepatic failure, should be avoided in patients with hepatic failure, and it should have use with caution in those patients with hepatic impairment. For posaconazole, it should not be used during pregnancy or lactation except the benefit outweighs the risk because this drug crosses the placenta or enters the breast milk. It also needs caution in patients with liver impairment, and we need monitor the patients for bone marrow suppressions and gastrointestinal and liver toxicity. Binofin, it is associated also with severe liver toxicity, contraindicated with liver failure, and should not be used during pregnancy or lactation except the benefit outweighs the risk because again it crosses the placenta and enters the breast milk. Lastly, for voriconazole, it should not be used with any other drugs that prolong the QTC interval or corrected for heart rate because it may increase and cause ergotism if taken with ergot alkaloid. Again, for adverse effects, most of the drugs is associated with liver toxicity and crosses the placenta or enters breast milk. That may cause severe effects on the fetus and to the neonate. For the drug-to-drug interactions, for ketoconazole and fluconazole, the words you can see are the drugs that is combined either with ketoconazole or fluconazole. If mixing the drugs cannot be avoided, you must monitor the patients closely and check if it needs dose adjustments. Meanwhile, for itraconazole, below are the drugs that should not be mixed as it may result to serious cardiovascular problems. And for voriconazole and posaconazole, drugs that prolong the QTC interval should be avoided as well as with ergot alkaloids. Another class is the echinocandin antifungal, a water-soluble cyclic lipopeptide. Drugs like anidulafungin or Araxis, caspofungin or Cansidas, and micafungin or Micamin belongs to this class. If azoles bind to sterols, the echinocandin inhibit the glucan synthesis. This may lead to death of the cell wall due to the blocking. Here is the video.
Echinocandins inhibit the synthesis of beta-1,3-glucan, which is required for cross-linking between chitin and beta-1,3-glucan that gives toughness to the cell wall.
Next, for the pharmacokinetics of the drugs, for anidulafungin, it is administered via IV with a rapid onset of action, metabolized by degradation, excreted through feces with a half-life of 40 to 50 hours. Meanwhile, for caspofungin, it is also administered via IV, absorbed slowly, metabolized in the liver with a half-lives of 9 to 11 hours, then 6 to 48 hours, and 40 to 50 hours. It is excreted in urine. Lastly, for micafungin, it is also administered via IV, absorbed rapidly with a half-life of 14 to 17 hours, and excreted through urine. As for the contraindications and cautions, anidulafungin should not be used during pregnancy or lactation except the benefit outweighs the risk. Because again, it may cross the placenta and enters the breast milk, and it also needs caution with patients who have hepatic impairment because it can be toxic to their liver. Same as with anidulafungin, caspofungin drug can be toxic to the liver with patients who have hepatic impairment, and it is also known to enter the breast milk, thus it should not be used during pregnancy or lactation, and except the benefit outweigh the risk. Lastly, for the micafungin, it is also should not be used during pregnancy or lactation, except again the benefit outweigh the risk because of the potential for adverse reactions in the fetus or to the neonate. Again, for the adverse effect, anidulafungin and caspofungin are associated with hepatic toxicity and potentially serious hypersensitivity reactions have occurred with micafungin. We also need to monitor for the bone marrow suppressions. For the drug-to-drug interactions, for anidulafungin, there are no demonstrated any drug-to-drug interactions, while simultaneously use of this drug, caspofungin, with cyclosporine should be avoided unless again the benefit outweigh the risk of hepatic injury. Lastly, for micafungin, there's also no any demonstrated with any drug-to-drug interactions.
So now we are going to proceed to other antifungal drugs that do not belong on the classes discussed by Ms. Langara. So we have here amphotericin B, flucytosine, griseofulvin, and nystatin. And to understand better the therapeutic actions of these drugs, let's try to examine this illustration. So in the antifungal, we have drugs which basically act on cell wall, on the cell membrane, and on nucleic acid synthesis. And so what we need to remember is in the fungal cell, you have an inner one, which is the cell membrane, and the outer one, which is the cell wall. So in the fungal cell wall, we have a beta-glucan, which is very, very important. And on the other hand, in the fungal membrane, we have the ergosterol, which is very important on the membrane as well. So we have a drug that binds to ergosterol in the cell membrane and create pores like this, which leads to the leakage of ions from the fungal cell, killing the fungus. So the drug that leads to formation of pores by binding to ergosterol is the amphotericin B and the nystatin. So you can remember this as amphotericin. Po means it creates pores in the cell membrane, and in addition to the fungicidal activity, unfortunately, amphotericin B also binds to cholesterol molecules found in human cell membranes, and although with relatively lower affinity, this, however, has major adverse consequences because binding to cholesterol also leads to the formation of pores that increase the membrane permeability, particularly in the renal vasculature and renal epithelial cells, which can ultimately lead to nephrotoxicity. So because of this, amphotericin B is typically reserved only for treatment of severe systemic infections that require a rapid response. So nystatin, although nystatin has the same mechanism of action as amphotericin B, nystatin is more toxic, and because of that, it is not used systematically. So it is also not absorbed from mucous membrane and skin, which is why its use has been largely limited to the treatment of superficial candida infections of the mouth, skin, and intestinal tract and vagina. So now, proceeding to drugs that inhibit the nucleic acid or the DNA of the fungus, that is the phocytosine. And lastly, we have a drug that disrupts the mitotic spindle and inhibit fungal mitosis, and that is the grisofulvin. So remember grisofulvin, it prevents the grease-like movement of mitotic spindle. So grease-like movement or smooth movement of spindle fiber. It is stopped by grisofulvin. So amphotericin B usually has half-life of 24 hours or 1 day to 15 days, and after that it will be excreted in the urine. And flucytosine is usually administered orally since it is well absorbed in the GI tract, but it is available in other forms too. So this has a half-life of 2 hours, of 2.4 hours to 4.8 hours. On the other hand, grisofulvin is administered orally and reaches peak levels in around 4 hours and a half-life of 24 hours. Lastly, nystatin is not absorbed from the GI tract as well and passes unchanged in the stool. That is why it is not administered orally. So its half-life is 5 to 7 hours. So amphotericin B has been used successfully during pregnancy, but it should be used cautiously since it crosses into breast milk, so it should not be used during lactation because of the potential risk to the neonate. So we know that phocytosine is excreted primarily in the urine, so extreme caution is needed in the presence of renal impairment because drug accumulation can occur. And now, because of the potential for adverse reaction in the fetus or the neonate, grisofulvin should be used during pregnancy and lactation only if the benefits clearly outweigh the risks. And on the other hand, it is not known whether nystatin crosses the placenta or enters the breast milk, so it should not be used during pregnancy or lactation unless the benefits clearly outweigh the potential risks. So these drugs are known to have toxic effects on the liver and kidneys, so it is very important that we as a nurse monitor our patient for any changes on these organs. And bone marrow suppression, rash, and dermatological changes should be monitored as well. So amphotericin B specifically is also associated with GI irritation with nausea, vomiting, and potentially severe diarrhea, anorexia, weight loss, and pain at the injection site with the possibility of the phlebitis or thrombophlebitis. So on the other hand, the adverse effects of grisofulvin are relatively mild with headache and central nervous system changes occurring most frequently. So patients who receive amphotericin B should not take other nephrotoxic drugs such as nephrotoxic antibiotics, cyclosporine, or corticosteroids unless absolutely necessary because of the increased risk of severe renal toxicity.
Now let's go for the nursing considerations for patients receiving systemic antifungal. We need to get the assessment. This includes the history and the physical examination. Assess the patient for contraindications or caution. This is getting the history if the patient has an allergy to drugs, liver or renal dysfunction, and if pregnant or nursing women. Next is to perform a physical assessment to establish baseline data. This includes test orientation and reflexes to evaluate CNS. We need also to examine the skin color and lesions or other dermatological effects. Third one is obtain a culture of the infected area to make an accurate determination of the type and responsiveness of the fungus. Next is to evaluate renal and hepatic function tests and the complete blood count to determine the function of these organs and to assess for possible toxicity. We have also for nursing diagnosis, this may include the following: acute pain related to GI, CNS, and local effects of the drug, disturbed sensory perception related to CNS effects, and deficient knowledge regarding drug therapy. For cloning, the patient will receive the best therapeutic effect from the drug therapy. The patient will have limited adverse effects to the drug therapy, and the patient will have an understanding of the drug therapy, adverse effects to anticipate, and measures to relieve discomfort and improve the safety. For implementation, we have to arrange for appropriate culture and sensitivity tests before beginning therapy to ensure the appropriate drug is used. And we also need to administer the entire course of the drug to get the full beneficial effects of the drug and to monitor the IV sites to ensure that phlebitis or infiltration does not occur. We also need to monitor the renal and hepatic function before and periodically during treatment to assess for possible dysfunction and if needs to stop the use of the drug if signs are present for hepatic and renal failure. We also need to provide comfort and safety provisions if CNS effects occur to protect the patient from injury and provide small, frequent nutritious meals if GI upset is severe, and we also need to monitor the nutritional status. We also need to instruct the patient to enhance patient knowledge to promote compliance and also a health teaching about the dosage, safety precautions, oral drugs with meals, and the effects of drugs. For evaluation, we need to monitor the patient's response to the drug, monitor for adverse effects, also evaluate the effectiveness of the teaching plan, and monitor the effectiveness of comfort and safety measures and compliance with the regimen. So that's it for the systemic antifungal. Now let's hear from Ms. Gonzalez about the topical antifungal.
We are now on the topical antifungal agents. Some antifungal drugs are available only in topical forms for treating a variety of mycoses of the skin and mucous membrane because these drugs are often too toxic for systemic administration. So care is necessary when using them near open or draining wounds that might permit systemic absorption. So these are the drugs that we are going to focus into. Let's go back with the illustration earlier to understand how this works. So the topical antifungal drugs work to alter the cell permeability of the fungus, causing and prevention of replication and eventually fungal death. Um, as what I've mentioned earlier, topical drugs are not absorbed systematically. So basically, these drugs do not undergo metabolism or excretion in the body, and because of these, contraindications are limited to a known allergy to any of these drugs and open lesions. Iconazole can cause intense local burning and irritation and should be discontinued if these conditions become severe. Gentian violet stains skin and clothing bright purple, and it is very toxic when absorbed, so it cannot be used near active lesions. Naphthalene, oxyconazole, and ceratoconazole nitrate should not be longer used for 4 weeks due to the risk of adverse effects and possible emergence of resistant strains of fungi. Same goes with sulconazole, but its usage is limited to 6 weeks. On the other hand, terbinafine should not be used for longer than 4 weeks. These drugs should be stopped when the fungal conditions appears to be improved or if local irritations and pain become too great to avoid toxic effects. And lastly, the efinaconazole must be applied with the supplied flow-through brush applicator. So now what are the adverse effects or the side effects of these drugs? So when these drugs are applied locally as a cream, lotion, or spray, local effects include irritation, burning, rash, and swelling. But when they are taken as a suppository or troche, adverse effects include nausea, vomiting, hepatic dysfunction, which is related to the absorption of some of the drug by the GI tract, or urinary frequency, and change in sexual activity, which is related to local absorption in the vagina. Now let's proceed to the nursing considerations for patients receiving topical antifungals. First, in the assessment, we need to assess for known allergy to any antifungal agent to prevent hypersensitivity reactions. And we need as well to perform a physical assessment to establish baseline data for evaluation of the effectiveness of the drug and the occurrence of any adverse effects associated with the drug therapy. Of course, we need to perform culture and sensitivity testing of the affected area to determine the causative fungus and appropriate medication. And so we are going to inspect too the area of application for color, temperature, and evidence of lesions to establish a baseline to monitor the effectiveness of the drug and to monitor for local adverse effects of the drug. So, nursing diagnosis related to drug therapy might include the following. First, the acute pain related to effects of the drug, or it could be deficient knowledge regarding the drug therapy, or risk for impaired skin integrity. So, as a nurse, our objectives would be the following. First, the patient will receive the best therapeutic effect from the drug therapy. Next, the patient will have limited adverse effects to the drug therapy, or the patient will have an understanding of the drug therapy, the adverse effects to anticipate, and measures to relieve discomfort and improve safety. And in order to achieve this, our nursing interventions would be first, culture the affected area before beginning therapy to identify the causative fungus, or patient must complete the drug regimen to achieve maximal results, and instruct patient with correct method of administration depending on the route to improve effectiveness and decrease the risk of adverse effects. And so troches should be dissolved slowly in the mouth. Vaginal suppositories, creams, and tablets should be inserted high into the vagina with the patient recumbent for at least 10 to 15 minutes after insertion. And topical creams and lotions should be gently rubbed into the affected area after it has been cleansed with soap and water and patted dry. Occlusive bandages should be avoided as well. Okay, so next we are going to advise our patient to stop the drug if severe rash occurs, especially if it is accompanied by blisters or if local irritation and pain are very severe, because this development may indicate a sensitivity to the drug or worsening of the conditions being treated. So next, I forgot to put this in the PowerPoint, but yeah, we need to provide patient instructions to enhance patient knowledge about drug therapy and promote compliance. And finally, we are going to provide the following patient teaching. First, we are going to teach them the correct method of drug administration and demonstrate proper application. Next, the length of time necessary to treat the infection adequately. The use of clean, dry socks when treating athlete's foot in order to help eradicate the infection. Um, the need to keep the infected area clean by washing with mild soap and water and patting it dry. The need to avoid scratching the infected area and use of cool compresses to decrease itching can be advised. Next, the need to avoid occlusive dressings because of the risk of increasing systemic absorption, and the importance of not placing drugs near open wounds or active lesions because these agents are not intended to be absorbed systematically. And of course, this is very important. The need to report severe local irritation, burning, or worsening of the infection to a healthcare provider. So now we are down to evaluation. So we need to monitor the patient response to the drug if the signs and symptoms of the fungal infection alleviates or something, and so we also need to monitor for adverse effects such as rash, local irritations, burning, and next, we need to evaluate the effectiveness of the teaching plan if patient can name the drug, the dosage, the possible adverse effects to watch for, and specific measures to help avoid adverse effects. And lastly, we need to monitor the effectiveness of comfort and safety measures and compliance with the regimen.
To end the topic, we provide you a prototype. This is what it looks like. For you to use, you can type in with this link to access it.
So now, let us take a closer look on the concept of antiprotozoal agents. So, the drug therapy of antiprotozoal agents differs across lifespan to the children, adults, and older adults. So, most antiprotozoal medications have strong effects on children, and using them might cause serious reactions. Many of these medications are not proved safe or effective in children, so use extreme caution. Adults should be educated on the importance of protozoal infection prevention and treatment. Calendars can be used to remind people to take drugs before, during, and after exposure. Notify your doctor if you are pregnant or nursing. If any of these drugs are used, women should be advised to use barrier contraception. A pregnant woman traveling to an area endemic with protozoal infections should be advised of the serious risks to the fetus associated with both preventive therapy and treatment of acute attacks, as well as the risks associated with contracting the disease. So these medication side effects may be more severe in older people, so they must be closely watched. And patients with hepatic dysfunction are more susceptible to toxicity and increasing hepatic issues. So if there is also a risk for hepatic dysfunction, or if it is expected due to extreme age, alcohol abuse, use of other hepatotoxic drugs, the dose should be lowered and the patient should be closely monitored.
Malaria is a parasitic disease that has killed millions of people and has changed the course of history. Even with the introduction of drugs for the treatment of this disease, it remains endemic in many parts of the world. The only known method of transmission of malaria is through the bite of a female Anopheles mosquito, an insect that harbors the protozoal parasite and carries it to humans. There are 4 protozoal parasites, all in the genus Plasmodium, have been identified as causes of malaria. First one is Plasmodium falciparum, which is considered to be the most dangerous type of protozoan. Infection with this protozoan results in an acute, rapidly fulminating disease with high fever, severe hypotension, swelling and reddening of limbs, a loss of red blood cells, and even death. The second one is the Plasmodium vivax, which causes a milder form of the disease, which seldom results in death. The third one is the Plasmodium malariae, which is endemic in many tropical countries and causes very mild signs and symptoms in the local population. It can cause more acute disease in travelers to endemic areas. The fourth one is the Plasmodium avele, which is rarely seen and seems to be in the process of being eradicated. A major problem with controlling malaria involves the mosquito that is responsible for transmitting the disease. The mosquito has developed a resistance to insecticides designed to eradicate it. The rise of insecticide-resistant mosquito has allowed malaria to continue to flourish, increasing the incidence of the disease. In addition, the protozoa that causes malaria has developed strains resistant to usual anti-malarial drugs. This combination of problem and factor has resulted to world challenge. So, the life cycle of the protozoa. The parasite that causes human malaria spend part of their life in the Anopheles mosquito and part in the human host. These gametocytes mate in the stomach of the mosquito and produce zygote that goes through several phases before forming sporozoites that make their way to the mosquito's salivary glands. These organisms travel through the bloodstream where they quickly become lodged in the human liver and other tissues and invade the cells. Inside human cells, the organisms undergo a sexual cell division and reproduction. Sporozoites enter the blood and invade the red blood cells. Many of the tissues cousins lay dormant until they eventually find their way to the liver to multiply and invade more red blood cells, again causing the acute cycle. This may continue years for the untreated patient. With Plasmodium falciparum malaria, there are no extrahepatic sites for this cousin. If the patient survives an acute attack, no prolonged periods of relapse occur. The first attack of this type of malaria can destroy so many red blood cells that the patient's capillaries become clogged, and the circulation of vital organs is interrupted, leading to death. Anti-malaria drugs are usually given in combination form to attack the plasmodium at various stages of its life cycle. Using this approach, it is possible to prevent the acute malaria reaction in individuals who have been infected by the parasite. Quinine or the chloroquine was the first drug found to be effective in the treatment of malaria. Other antimalarials used today include chloroquine or aryl phosphate with generic morofloquine and primaquine, and ferromethamine or dorafine. The table shows the dosage and route of the antimalarials with the indication for suppression, treatments, and prevention in pediatrics and adults. Two fixed combinations of drugs are available for use in the prevention and treatment of malaria. Combining two different preparations in one drug may increase the compliance by reducing the number of pills a patient has to take. And it conforms to the treatment protocol of taking drugs that affects the protozoa at different stages in their life cycle. They are indicated for the prevention of Plasmodium falciparum malaria when chloroquine resistance has been reported. They are used for the treatment of uncomplicated P. falciparum malaria when chloroquine, halofantrine, and meloxicam have proven unsuccessful, most likely because of resistance. So the table here shows the antibiotics to treat malaria. So pharmacokinetics. Chloroquine is readily absorbed from the gastrointestinal or GI tract with peak serum levels occurring to 1 to 6 hours. It is concentrated in the liver, spleen, kidney, and brain and excreted very slowly in the urine, primarily as unchanged drug. Meloxicam is a mixture of molecules that are absorbed, metabolized, and excreted at different rates. The terminal half-life is 13 to 24 days. Metabolism occurs in the liver, and caution should be used in patients with hepatic dysfunction. Primaquine is readily absorbed and metabolized in the liver. Excretion occurs primarily in the urine. Safety for use during pregnancy has not been established. Pyrimethamine is readily absorbed from the GI tract, with peak levels occurring within 2 to 6 hours. It is metabolized in the liver and has a half-life of 4 days. It is usually maintains suppressive contractions in the body for about 2 weeks. Quinine is rapidly absorbed from the GI tract with peak serum levels occurring in 1 to 3 hours. It is metabolized in the liver with a half-life of 4 to 6 hours and is excreted in the urine. Antimalarials are contraindicated in the presence of known patient allergies to any of these drugs, liver disease or alcoholism, both because of the parasitic invasion of the liver and because of the need of the hepatic metabolism to prevent toxicity, and lactation because of the drugs can enter breast milk and could be toxic to the infant. It is contraindicated also to pregnancy because they are associated with birth defects. Use caution, and patients with retinal disease or damage because many of these drugs can affect vision and retina, and the likelihood of problems increases if the retina is already damaged. With psoriasis and porphyria because of the skin damage or with damage to mucous membrane, which can occur as a result of these effects to the drug and protein synthesis. Patients with glucose 6-phosphate dehydrogenase or the G6PD deficiency, which is more likely to occur in Greeks, Italians, and other people of the Mediterranean descent, may experience a hemolytic crisis if they are taking the anti-malarial agent, chloroquine or primaquine. Immune reaction effects related to the release of merozoites include fever, shaking, chills, and malaise. Nausea, vomiting, dyspepsia, and anorexia are associated with direct effects of the drug to the GI tract and effects to sinus control of vomiting caused by the products of cell death and other protein changes. Hepatic dysfunction is associated with toxic effect of drugs and in the liver and the effects of disease on the liver. Dermatological effects include rash, pruritus, and the loss of hair associated with changes in protein synthesis of the hair follicles. Synchronism, nausea, vomiting, tinnitus, and vertigo may occur with high levels of quinine and primaquine. Next is the patient is receiving combinations of quinine derivatives and quinine is at risk for cardiac toxicity and convulsions. Therefore, monitor the patient closely, checking drug levels and anticipating dose adjustment as needed. Increased bone marrow suppression may occur in anti-inflammatory drugs. Methotrexate, fulsonamides, or etc. Methylamine if signs of folate deficiency develop.
Nursing considerations for patients receiving antimalarial agents. So the first part is the assessment, which includes history and examination. Assess for contraindications or cautions, history of allergy to any of the antimalarials to prevent hypersensitivity reactions, liver dysfunction or alcoholism that may interfere with the metabolism and excretion of the drug, porphyria or psoriasis, which could be exacerbated by the drug effects, retinal disease that could increase the visual disturbances associated with these drugs, and pregnancy and lactation because these drugs could affect the fetus and could enter the breast milk and to be toxic to the infant. Next is perform a physical assessment to establish baseline data for assessment of the effectiveness of the drug and the occurrence of any adverse effects associated with the drug therapy. Assess central nervous system and perform ophthalmic and retinal examinations and auditory screening to determine the need for cautious administration and to evaluate changes that occur as a result of drug therapy. Assess the patient's liver function, including the liver function test to determine appropriateness of therapy and to monitor for toxicity. Obtain blood culture to identify the causative Plasmodium species and ensure appropriate use of the drug. Inspect the skin closely for color, temperature, texture, and evidence of lesions to monitor for adverse effects. So in nursing diagnosis related to drug therapy might include acute pain related to gastrointestinal, central nervous system, and skin effects of the drug. Disturbed sensory perceptions related to central nervous system effects, risk for injury related to central nervous system changes, deficient knowledge regarding drug therapy implementation with rationale, arrange for appropriate culture and sensitivity tests before beginning therapy to ensure proper drug for susceptible Plasmodium species. Treatment may begin before test results are known. Administer the complete course of the drug to get the full beneficial effects. Mark a calendar for prophylactic doses. Use combination therapy as indicated. Monitor hepatic function and perform ophthalmological examination before and periodically. During treatment, to ensure early detection and prompt intervention with cessation of drug if signs of failure or deteriorating vision occur. Provide comfort and safety measures if central nervous system effects occur to prevent patient injury. Provide oral hygiene and ready access to bathroom facilities as needed to cope with GI effects. Provide small, frequent, nutritious meals if GI upset is severe to ensure adequate nutrition. Monitor nutritional status and arrange a dietary consultation as needed. Taking the drug with food may also decrease the GI upset. Instruct the patient concerning the appropriate dosage regimen and the importance of adhering to the drug schedule to enhance patient knowledge about drug therapy and promote compliance. So patient teaching should be provided. Take safety precautions, including changing position slowly and avoiding driving and hazardous tasks if central nervous system effects occur. Take the drug with meals and try small, frequent meals if GA upset is a problem. Report blurring of vision, which could indicate retinal damage, loss of hearing or ringing in the ears, which could indicate central nervous system toxicity, and fever or worsening of condition, which could indicate a resistant strain or non-effective therapy. So the last part is the evaluation. Monitor patient response to the drug, monitor adverse effects, such as the orientation and affect, nutritional state, skin color and lesions, hepatic function and visual and auditory changes, and evaluate the effectiveness of the teaching plan. Patient can name the drug, dosage, possible adverse effects to watch for, and specific measures to help avoid adverse effects, and monitor the effectiveness of comfort and safety measures and compliance with the regimen.
So the following are the other protozoal infections: amoebiasis, leishmaniasis, trypanosomiasis, trichomoniasis, giardiasis, and pneumocystis jirovecii pneumonia. So amoebiasis is an intestinal infection caused by Entamoeba histolytica. This organism exists in two stages. First is a cystic dormant stage in which the protozoan can live for long periods outside the body or in the human intestine. And the second stage, or the trophozoite stage, which lives in the ideal environment or in the human large intestine. So this disease is transmitted while the protozoan is in the cystic stage in fecal matter, from which it can enter water and the ground. It can be passed to other humans who drink this water or eat food that has been grown in this ground. So cysts ingested by the host enter the intestinal tract and produce trophozoites. Trophozoites enter the bloodstream to reach tissue, and then will eventually enter the liver, the lungs, heart, brain, and spleen, which can be fatal to the host. Trophozoites are excreted in the stool and die because the outside environment is not conducive for it to live. So the cysts excreted in the stool contaminates the water and can be ingested by the host, which will eventually begin the cycle of infection to the host. Amoebiasis causes mild to severe diarrhea. If the protozoan can infiltrate extra-intestinal tissue, it can destroy it and eventually kill the host. So some people become carriers of the disease without showing any symptoms. These patients seem immune to the intestinal invasion, but they pass the cysts in stools. So for leishmaniasis, it is a protozoal illness. It is from sandflies. It is carried from sandflies to humans. And a promastic goat is an asexual form injected by these sandflies that is quickly targeted and digested by the human macrophages. So inside the macrophages, the promastigote divides, developing many new forms called amastigotes, which can eventually kill the macrophage, releasing the amastigotes into the system to be devoured by more macrophages. Thus, a cyclic pattern of infection can begin, or it is the result of this. And it can cause serious cutaneous, visceral, or mucous membrane lesions. For trypanosomiasis, it is caused by infection with Trypanosoma. It is two parasitic protozoal species cause very serious and often fatal diseases in humans. So for the African sleeping sickness, these are caused by Trypanosoma gambiense. These are transmitted by the tsetse fly, lives and grows in human blood, invades the CNS, leading to an acute inflammation that results in lethargy, prolonged sleep, and even death. For Chagas disease, it is caused by Trypanosoma cruzi, transmitted by the common housefly, and causes severe cardiomyopathy. For trichomoniasis, it is caused by Trichomonas vaginalis, and which is the common cause of vaginitis, and this infection is usually spread during sexual intercourse by men who have no signs and symptoms of infection, and in women, this protozoan causes reddened, inflamed vaginal mucosa, itching, burning, and a yellowish-green discharge. Giardiasis is caused by Giardia lamblia. It has two stages, a cystic and trophozoite stage, and follows the cycle just like the Entamoeba histolytica that causes amoebiasis. So, the signs and symptoms for this disease include diarrhea, rotten egg-smelling stool, pale and mucus-filled stool, epigastric distress, weight loss, and malnutrition. For Pneumocystis jirovecii pneumonia, it is caused by Pneumocystis jirovecii. It is an endemic protozoan that does not usually cause illness in humans. So when an individual's immune system becomes suppressed because of AIDS or AIDS-related complex, the use of immunosuppressant drugs, or due to old age, this parasite is able to invade the lungs, leading to severe inflammation and a condition known as Pneumocystis jirovecii pneumonia. This disease is the most common opportunistic respiratory infection in patients with AIDS. So the other antiprotozoal agents include atovaquone, which has a brand name commonly known as Mepron, and its usual indication is for prevention and treatment of Pneumocystis jirovecii pneumonia. It is usually combined with proguanil for treatment of chloroquine-resistant malaria. On the other hand, metronidazole has a brand name commonly called Flagyl, Metrogyl, and Noritate. It is used for treatment of amoebiasis, trichomoniasis, and giardiasis. Nitazoxanide has a brand name called Alinea, and its usual indication is for the treatment of diarrhea associated with Cryptosporidium parvum or Giardia lamblia. On the other hand, pentamidine has a brand name commonly called as Pentam 300 or Nibupent. It is an inhalation treatment for Pneumocystis jirovecii pneumonia, and it acts as a systemic agent in the treatment of trypanosomiasis and leishmaniasis. Furthermore, tinidazole has a brand name commonly called Tindamax, and it is a treatment of trichomoniasis, giardiasis, and amoebiasis. So the pharmacokinetics of these antiprotozoal agents are the following. For atovaquone, it is available only as an oral suspension. It is slowly absorbed and highly protein-bound in circulation and excreted slowly through the feces with a half-life of 67 to 76 hours. For metronidazole, it is well absorbed orally. It reaches peak levels in 1 to 2 hours, metabolized in the liver with a half-life of 8 to 15 hours, and excretion occurs primarily through the urine. Nitazoxanide is rapidly absorbed after oral administration, and it reaches peak levels in 1 to 4 hours. It is metabolized in the liver, excreted in the urine and feces, and has a half-life of 8 to 12 hours. Pentamidine is readily absorbed through the lungs since it is an agent that is through inhalation, and its excretion occurs in the urine with traces found in the urine for up to 6 weeks. So the tinidazole is rapidly absorbed after oral administration, and it reaches peak levels within 60 to 90 minutes. It is excreted in the urine with a half-life of 12 to 14 hours. So the therapeutic actions and indications of these antiprotozoal agents is that they act to inhibit DNA synthesis in susceptible protozoa, which interferes the cell's ability to reproduce, subsequently leading to cell death. So the contraindications and cautions for these agents are the following. The presence of allergy or hypersensitivity to any of these drugs. This is in order to prevent hypersensitivity reactions, the presence of pregnancy, because drug effects on developing fetal DNA and proteins can cause fetal abnormalities and even death. So, we have also to use caution when administering these drugs to patients with CNS disease or central nervous system disease because of possible disease exacerbation due to drug effects on the CNS, and to patients with hepatic disease because of possible exacerbation when hepatic drug effects occur, and to patients with candidiasis because of the risk for superinfections. This should also We should also use caution when administering this to women who are lactating because these drugs may pass into breast milk and could have severe adverse effects on the infant. Furthermore, the safety and efficacy of pentamidine in children have not been established, so this is a caution that must be observed. And then, tinidazole should never be combined with alcohol and should be used with caution in patients with renal dysfunction because it could interfere with the excretion of the drug. So the adverse effects or the possible adverse effects for these antiprotozoal agents are are CNS effects, which are headache, dizziness, ataxia, loss of coordination, peripheral neuropathy, and GI or gastrointestinal effects, which are nausea, vomiting, diarrhea, unpleasant taste, cramps, and changes in liver. And superinfections can also or may also occur. So, the following are the clinically important drug-drug interactions that should be noted. Tinidazole and metronidazole should not be combined with alcohol because it causes adverse effects. Metronidazole and tinidazole combined with oral anticoagulants can lead to increased bleeding, while tinidazole or metronidazole when combined with disulfiram can cause psychotic reactions.
Nursing considerations for patients receiving antiprotozoal agents. So, in the assessment, assess for contraindications and cautions, history of allergy to any of the antiprotozoals to prevent hypersensitivity reactions, liver dysfunction that might interfere with metabolism and excretion of the drug or be exacerbated by the drug, pregnancy, which is a contraindication, and lactation because these drugs could enter the breast milk and be toxic to the infant, central nervous system disease that could be exacerbated by the drug, and candidiasis that could become severe as a result of the effect of these drugs on the normal flora. Perform a physical assessment to establish baseline data for determining the effectiveness of the drug and the occurrence of any adverse effects associated with the drug therapy. Evaluate the central nervous system to check reflexes and muscle strength to identify the need for cautious drug use and to evaluate changes that occur as a result of drug therapy. Examine the skin and mucous membranes to check for lesions, color, temperature, and texture to monitor for adverse effects and superinfections. Evaluate liver function, including liver function tests, to determine the appropriateness of therapy and to monitor for toxicity. Obtain cultures to determine the exact protozoal species causing the disease. Next is nursing diagnosis. Nursing diagnosis related to drug therapy might include acute pain related to gastrointestinal and central nervous system effects of the drug, imbalanced nutrition, less than body requirements related to severe GI effects of the drug, disturbed sensory perception related to central nervous system effects, deficient knowledge regarding drug therapy, diarrhea related to GI effects of the drug. Next is the implementation with rationale. Arrange for appropriate culture and sensitivity tests before beginning therapy to ensure proper drug for susceptible organisms. Treatment may begin before test results are known. Administer a complete course of the drug to get the full beneficial effects. Use combination therapy as indicated. Monitor hepatic function before and periodically during treatment to arrange to effectively stop the drug if signs of failure or worsening liver function occur. Provide comfort and safety measures if central nervous system effects occur, such as side rails and assistance with ambulation if dizziness and weakness are present, to prevent injury to the patient. Provide oral hygiene and ready access to bathroom facilities as needed to cope with GI effects. Arrange for the treatment of superinfections as appropriate to prevent severe infections. Provide small, frequent, nutritious meals if GI upset is severe to ensure proper nutrition. Monitor nutritional status and arrange a dietary consultation as needed. Taking the drug with food may also decrease GI upset. Instruct the patient about appropriate dosage regimen to enhance patient knowledge about drug therapy and promote compliance. So provide the following patient teaching. Take safety precautions including changing positions slowly and avoiding driving and hazardous tasks if central nervous system effects occur. Take the drug with meals and try small frequent meals if GI upset is a problem. Follow drug dosing guidelines carefully. Report severe GI problems and interference with nutrition, fever and chills which may indicate the presence of a superinfection, and dizziness, unusual fatigue or weakness which may indicate central nervous system effects. So in the evaluation, monitor the patient response to the drug, monitor for adverse effects, orientation and affect nutritional state, skin, color and lesions, hepatic function, and occurrence of superinfections. Evaluate the effectiveness of the teaching plan. Patient can name the drug dosage, possible adverse effects to watch for, and specific measures to help avoid adverse effects. Monitor the effectiveness of comfort and safety measures and compliance with the regimen.
That would be all for the other antiprotozoal agents.